Recently, we've had quite a lot of bad press, I would say, about novel oral anticoagulant drugs because of excess bleeding. And some of this bad press has suggested that we should be measuring blood levels of these non-VKA oral anticoagulants. Other people, of course, need to measure blood levels in particular hazardous situations. But for various reasons, there's a big emphasis on whether we should do this. What's your position on this, Fried?
Yeah, John, thank you. One of the advantages of the NOACs is that you don't have to measure the anticoagulation status, but it's also a potential disadvantage, for instance, when there is bleeding or when the patient needs surgery. And therefore, there have been now several studies looking at the techniques we currently use to establish the anticoagulation status in patients who are on a NOAC. Of course, dabigatran is the oldest one we know now, and since it blocks the activity of thrombin, APTT, the activated partial thromboplastin time, should be a valuable measurement. But if you look, for instance, at this study, you see that we at least have 5 assays for APTT. And if you look more closely to the, for instance, with dabigatran, the blood levels, the trough and the peak levels, you see that it prolongs APTT, but not to a large extent. And secondly, this is data from 2 hours after the intake of the drug. But the only good thing is that it's quite linear, so APTT is prolonged shortly after the dabigatran intake. So it is the only useful test we have, an ad hoc test in an emergency room environment, which can approach the anticoagulation status of dabigatran. More complex is the situation with the 10A blockers, and there is quite some experience now with rivaroxaban on plasma levels. And since the 10A blockers, of course, block the formation or the activation of thrombin, from prothrombin into thrombin, we can measure prothrombin activity in the plasma. And here you see the results with the rivaroxaban. Again, you see here the trough and peak levels of rivaroxaban, and also you see here some prolongation, not with all the assays, but some assays, prolongation of the prothrombin time when patients are 2 hours away from the intake of rivaroxaban. But again, the prolongation is not very impressive, and therefore it is rather cumbersome to use this prothrombin time measurement. On the other hand, all hospitals have 24 hours around the clock this measurement available. The optimal way, of course, to measure at least the 10A blockers is the assay of anti-10A activity in the plasma. And there, for instance, with apixaban, we see a very good correlation between apixaban plasma levels and the anti-10A activity in the plasma. This is an excellent test, but it is complex, it is expensive, and in most institutions it is not available 24 hours around the clock. So it remains cumbersome, I think, this detectability of the NOAC in the plasma in situations of bleeding and when patients need urgent surgery. There has been a very nice overview recently in JACC it's in fact a meta-analysis of all the studies done with the NOAC with regard to its anticoagulation status, and they come to this, I think, useful slide. Here you see the 3 major NOACs, dabigatran, rivaroxaban, and apixaban, where the studies were performed with. And here you see the several tests we have that can detect the activity of the NOAC in the plasma. If you look at dabigatran, thrombin time could be useful, but as you see in the hatched parts of these histograms, the linearity which you would like to see is not available in the on-therapeutic range. Whereas you have it with APTT, the green bar. There is an acceptable linearity. I showed you already in my previous slide. So you may use APTT as an approaching or estimate the activity of dabigatran in the plasma. Prothrombin time is not useful, since it only can be detected when the patient has too much of dabigatran on board. With the 10A blockers, it's a bit different. As pointed out already, anti-10A activity is by far the most appropriate. That is true for rivaroxaban as well as apixaban, because these are specific 10A blockers. But prothrombin time, I showed you in the previous slide, may be used with rivaroxaban because there is quite some linearity between the prolongation of prothrombin time in relation to plasma levels of rivaroxaban. This has not been very well established with apixaban. There, the optimal measurement is the anti-10A activity in the plasma. But again, this is not 24 hours around the clock available in many places. So to summarize, and that was an editorial written by the group of Greg Lipp in JACC on this important meta-analysis of all these texts, is a simple table. What should we use? In the preferred method I showed you for NOAC is, in fact, the thrombin time, but only when you dilute it, or an Eckerin plotting time, which is hardly used in clinical practice. And in an emergency room environment, APTT is the only one, in fact, which you may use with all its shortcomings. For rivaroxaban, ideal is the anti-10A activity, and in emergency room situations, the prothrombin time may estimate more or less the activity of the drug in the plasma. And apixaban, I told you, anti-factor 10A activity, of course, is the best we have, but not available in many places. And then you may use the dilute prothrombin time. For in edoxaban, we have too little data to give any advice. So that's about it.
So it is possible to measure the anticoagulation status both qualitatively and quantitatively, but the quantitative information that we have requires relatively expensive tests, and many hospitals don't have them, and if they do have them, they're not available, as you say, around the clock.
Yeah, that is. I think it's a problem when patients start to bleed and they come into the emergency room. You don't know whether it's due to the NOAC or not due to the NOAC, and also the timing of the NOAC is important. If the drug has been taken, for instance, 12 hours before the bleeding started, the measurements are completely unreliable, and you don't have anything to measure. Where we can measure with VKA the anticoagulation status quite accurately. So this, but in the trials though, when we look at the bleeding, which is less with NOACs, and especially the fatal bleedings, despite we don't have good measurements of monitoring, the bleeding is less. So maybe this is not very important, but I still think it is important, especially in case of severe bleeding and in emergent surgery. For instance, a ruptured aneurysm of the aortic, abdominal aortic aneurysm.
Raphael, do you find it necessary to measure the blood levels of novel oral anticoagulants ever? Is it an important thing to be able to do this?
It is probably a need in certain situations, spot measuring the levels of anticoagulation. But I would not venture into the idea that some people are putting forward of routine monitoring in some patient categories. Spot measurement is important in some situations, bleeding, preparation for surgery, in a patient that has received a NOAC without too much knowledge about the time of interruption of the drug, or knowing whether there is enough level of anticoagulant on board to compromise hemostasis. But these are occasions in which the laboratory needs to be prepared and needs to be really ready for this spot measurement with the specific tests, which, as we said, is not something very easy because these are very rare occasions, and we have experienced that when you run a test only once a month rather than on a routine basis, you have problems because the rapidity, the ability to react quickly in a situation in which you need to perform the test is some way compromised by the lack of exercise by laboratory people to do this. So this is one problem. The other problem is that each of these tests really needs to be calibrated with the specific NOAC. So it's Frake has shown that even a routine test such as the APTT can give you wide variations according to the reagents you use. So from these, the need of each laboratory to try to figure out which reagent to use for the test in case a monitoring of dabigatran, apixaban, rivaroxaban, edoxaban would be needed. I certainly would not venture at all at the moment in the idea of routine monitoring in some patients, and I want to expand a little bit on this. Despite the fact that there are good reasons to believe that some people have higher plasma levels than others because of compromised renal function, for example, or because the propensity to bleeding in some situations, like in the elderly, can be higher. This does not necessarily translate into an improvement of care by routine monitoring. I can give you the simple example of something that is very rational but does not translate into practice, and this is the monitoring of clopidogrel action in cardiology. Clopidogrel is a drug that is very highly variably metabolized in different people because of polymorphisms and because of interaction with many other drugs. And there have been attempts at routinely assess in some categories either platelet function or the genetics behind the individuals. And these have been really fruitless exercises so far. And at the moment we don't have not a little piece of evidence that these can be recommended. So the burden of the proof for those who want to venture in this area would be upon them to show that by these additional expensive strategies you can gain on what we know already from the phase 3 clinical trials. Non-monitored NOACs are globally associated with a net clinical benefit compared to relatively well-monitored old-fashioned vitamin K antibodies.
But on the other hand, we are being badly criticized, or at least the drug companies, the pharma companies who develop these compounds are being badly criticized for not having established these methodologies for assessing plasma concentrations and for using them regularly. What's your position on that, Paulus?
I do think that the biggest problem that we face in stroke prevention in AF patients is the underuse of anticoagulants. And one of the miracles or one of the big advantages of the NOACs is that you can prescribe them and use them without a need to monitor. So you don't need a big infrastructure of any type. So you can do this in the outer Scottish Islands without a helicopter flying there every week to measure something, which is good. And that's important. And I think this is one of the main advantages when you look at these agents from the healthcare system perspective, that we will be able to deliver anticoagulation to more of those people that have a clear indication for it. And therefore, I concur with what Raf said. I don't think we want a precise assay. I think there are two rare scenarios where you would want some type of assay. But in my view, it's a simple assay. It is some scenarios, for example, if a patient on a NOAC comes in with an ischemic stroke and you want to know whether you can thrombolize them, you want to know whether that patient actually took the medication. So if we had a simple test, and I fully agree with Frank, it has to be a test that is available 24/7 everywhere in a normal healthcare setting. It cannot be anything fancy, expensive, or that takes a long time. If we had such a test, we would be able, our stroke neurologist colleagues would be able to thrombolize such patients. On the other hand, there may be rare occasions of severe bleedings where you want to establish whether the NOAC caused the bleed. And there you may want to be able to demonstrate that the patient actually took the medication. And therefore, again, you don't need a sophisticated plasma level. You actually, what we need is really a red-green assay, saying yes, NOAC is on board, or no, NOAC is not on board. NOAC has been taken. And I think if you think in those simple terms, then we already have quite a few indications, as you showed, Frank, so we can use some of the routine tests. And if the developments would go in that direction, we may actually have a bedside test for NOAC taken, NOAC not taken.
Marco, do you need a blood level of NOAC in your practice?
I can only reiterate what has been said before. Routine monitoring, in my view, is not necessary, and in cases of emergency, I think most importantly is to ask the patient, did you take your medicine, and what is the time between intake of medication and the event, and assess renal function. Very easy to be done. And then I can only repeat what Paulus has been saying. It's essays showing that your patient has been taking medication, that's very informative. I do think the essays that have been shown give us only qualitative information and not quantitative information.
Yes. And Johnny, in your practice, are you wanting to do measurements ever?
Really, I would say no. I agree with Marco, Paulus. There is a problem of emergency, of course, which is more the problem of emergency doctors, surgeon, anesthesiologists, and so on. For cardiologists, perhaps the only problem could be with cardioversion, not for the problem of the risk of bleeding, but to be sure of the compliance of the patient. And that may be sometimes a problem. Usually I speak with my patients telling him it's important for you to tell it, because if you have not taken your drugs, there is a risk of stroke. And I can tell you that the majority of patients say the truth about the fact that they were compliant. But if I have a doubt, I can do an assay in some cases to be like was saying by Paulus, yes or not, there is the drug in board or not. And we have also the possibility of making transesophageal echography, to make CT scans. And we have seen in the different publications, I mean the first one with the Bigatron from Niagara County. After that, we have seen with rivaroxaban from Piccini, if my memory is good, and also from Flecker with apixaban. And recently we have seen the XVER trial with rivaroxaban, saying that clearly we can make with a good safety this cardioversion. But cardioversion is a very frequent occurrence, so it's important to be sure of the compliance.
So I get the impression that we're agreed around the table, really, that there's no indication for regular monitoring of anticoagulation in patients taking non-VKA oral anticoagulants. We're also agreed that we don't need sophisticated techniques to measure accurately the quantitative degree of anticoagulation, but everybody would like to have simple measures for qualitative information the patient has been taking the drug or not. That seems to be where we are positioned, but we're still well aware of the fact that there's a lot of criticism out there, and there's a lot of push for us to consider using more accurate methods of assessing the anticoagulation status of patients. We'll see how that develops in the future.